Assalamualaikum warahmatullahi wabarakatuh. Brothers and sisters, welcome to another episode of Brothers Hour Special, a monthly special that takes place where we have conversations amongst brothers about all kinds of issues religious, educational, life issues, mental health and well being, any kind of issues that are important to our daily conversations um, and issues that we feel are close and important to your heart. Um, Before we announce our guest for the day, I'd like to invite the guests who are present and watching with us to share with us where are you watching from. I know we've got a lot of viewers in London, evidently, but also in Singapore, in Kuala Lumpur, and other parts of Malaysia. So, for those of you watching, do let us know where you're watching from. And as we progress through today's session, we hope that you can share your own comments and questions because I'm pretty sure there's going to be a lot of questions coming in. But before we get to that, as you know, SOFA has launched its charity calendar. And we know it's already coming up to March. But for those of you still looking for a calendar to plan out the year, especially with Ramadan just around the corner, SOFA has published a very beautiful charity calendar that includes all the sacred days of the Islamic calendar and the prayer times for those of you living in London. So please grab it while there's stock. I know it's going very quickly, but for those of you still wanting a calendar, please support SOFA, buy this beautiful calendar, and inshallah, by doing so, you're not just benefiting yourself, but also benefiting the community because all the proceeds from the calendar will go towards running our institution and all the programs that go with it. And secondly, in line with this blessed month of Rajab, uh, we've recently uh, we've recently announced the Rajab Fundraiser for 2021. So this fundraiser allows us and allows all of you to donate to the programs that mean the most to you. So there's two programs. One of them is the SOFA online programs that covers all the 6 online and free classes and programs that take place online. So as you already may be familiar with, we've got the Thursday classes, the Saturday classes, yeah, the online halakas. We've also got the Friday reminders as well as the Sunday invocation, and also we've got this our very well received, alhamdulillah, sisters hour and brothers hour special, and not forgetting the sofa story time that takes place every Wednesday. So a lot of online programs, a lot of work, and a lot of expenditure that goes to keeping all these programs running. So please consider supporting all those programs for the year by making a one-off donation. I think you can donate as little as £20 up to any amount that you wish. So please consider donating for a year and help us support that series of programs. Secondly, we've got the Revert, the Mu'allaf program, and this covers everything to do with support and care for reverts. So included with that program are monthly Mu'allaf circles, yeah, that teaches allows Mu'allafs and reverts to share their experiences of converting or reverting to Islam. We've got discussion circles where we invite guest speakers to share guidance and advice. We've got Fardu Ain series where our Ustad Zaki will be teaching them the fundamentals of the faith. And also we're planning to launch a gift hadiyah pack, what will basically be introductory pack for new Muslims. So you'll have prayer mat, prayer beads, a book that explains the fundamentals of the religion, everything that we hope will make a new revert feel welcome and informed as they begin their journey to Islam. So that's the second program, the Mu'allaf program. And please, if that's something that's close to your heart, consider donating towards that program as well. You can see link to the web page where you can make your donation on the comment section So it's basically www.thesofafoundation.org/sponsor-programs. So again, it's on the comment section. So I'd really appreciate if all of you could spend some time and go through that webpage and consider supporting any or both of these programs for the year. And inshallah, with your help and with your donation, the SOFA Educational Foundation can grow in strength and continue um, supporting the religious welfare of our community for the year ahead, inshallah ta'ala. So with that done, I'd like to introduce today's hot topic. Um, Today's topic is something that is constantly being discussed, and it's a hot topic. And I know there's a lot of questions and there's a lot of issues and opinions and informations being shared out there. But we've got a really special guest that hopefully will provide some data and provide some insight into this issue. So we're talking about the COVID vaccine, the COVID-19 vaccination, and inshallah today we're going to be debunking some of the myths to do with the COVID-19 vaccination. And here with us this afternoon is Dr. Kam Zaki. Assalamualaikum, doctor. I hope you're well.
Waalaikumsalam. Yes, I'm well, thank you.
Alhamdulillah. First of all, thank you so much for agreeing to come on our show. Dr. Kam is a consultant medical oncologist at Guy's Hospital. And also, as I'm aware from his Facebook, you've been really kind of researching into the vaccination. And if I may say so, you're a bit of a data geek, if you allow me to describe it that way.
Yeah, I'll take that as a compliment. Thank you.
Yes. But I've been following you on Facebook, and you've been sharing a lot of data and a lot of insight into the COVID vaccination. And I believe that you've already received your vaccinations yourself. Is that correct?
I have indeed. Yeah, Alhamdulillah, I've received the 2 doses of the Pfizer vaccine.
Great. So I think you're really well placed in our community to talk about, firstly, kind of your experience as a doctor in the front line and how COVID has impacted the NHS and your own experience at work. And hopefully, as we continue through the session, to talk about the vaccination and to address some of the myths that are associated with the vaccination. There's some crazy theories out there, but there's also reasonable concern that we hope that you can provide some insight to. So if you allow me to kind of get the ball rolling, can you share a little bit, Doctor, about your own experience working under a pandemic, and how has it impacted your work and your life?
Okay, yeah. Thank you, Ami. I suppose the first thing I want to say that despite being a medical doctor, my first and foremost specialty is oncology. So I treat cancer patients. So I'm going to start with a disclaimer saying that I am not a COVID-19 expert. I've never actually treated any COVID patients explicitly. As you say, I have received my COVID vaccines, and I've also recruited patients into COVID-related clinical trials, and I've seen the effect of COVID in some of my cancer patients. So, as a background, I am finishing a PhD in gene therapy, and part of the project is to develop antibody and vaccine treatment against cancer. So that's where my background is. So coming back to how this has affect work, so I will share my experience regarding what I can see and experience of the things that have been happening in my own department, in my own hospital. So this is quite a niche environment that I see. So to start with, I've got the vaccine because I'm a frontliner, and also because of my health condition. So I'm quite in a way quite lucky to fall into that category and get the vaccine. And also as a consequence of that, I have been working from home during the lockdown. So one of the way that we have changed the healthcare professional have changed the way they work is offering remote consultations. And I'm sure you guys know this anyway, because you can't see your GP, so your GP will call you or do a video consultation for you. Um, in terms of how the COVID-19 itself affect the NHS, we can, there are measurements that we can use, and the things that highlighted every day in the media are the number of cases, number of hospitalizations, and the number of deaths. During its peak, back in middle of January, we got about 4,000 cases of hospitalization per day, and that leads to about 40,000 uh, patients in hospital in one single day. And luckily, with the effect of the lockdown and potentially early vaccination effect, we are seeing this number coming down. Um, and coming back to the experience in the hospital so I'm working in the two big South London hospitals. So to give an example, normally we have 60 ITU beds per hospital. And at its peak, about coming to mid January to early February, we actually have 300 ITU beds. So from 60
Wow.
beds to 300 in each hospitals. So it's really stretched. So first of all, we have to make these beds, and secondly, we need to staff this bed. And as a result of that, we have to what we call redeployment of staff. So we need to get staff from somewhere. One of the hospital I work with is in a position where we actually, because in Southeast London, all the ITU beds in the district general hospitals were full, so we have to accept a lot of patients from other hospitals, and that's why there's a lot of expansion. So this comes with a price, and it comes with a price because we need nurses to man these ITU beds. So oncology nurses, research nurses, so who will usually do, what their day job is, running clinical trials, or be the advocate for patients, or who are the link for patients to the medical care. So they have to redeploy it, and they have to go to intensive care. Another example where staff are redeployed, and this includes junior doctors as well, is that we develop COVID wards. So patients who have COVID, they are placed in a dedicated ward. Against this wards needs to be staffed. I think in oncology, at least in my hospital, we have been very lucky, because we treat patients as usual, as much as we can, although we have to prioritize the patients that we have to treat. So we have so we do a few things. We modify treatment. In some patients, we have to delay treatment for patients who are and when also in very exceptional circumstance, we have to stop the treatment. But this is all done with discussion with patient, and also in a safe and and transparent manner. There are some patients who we think that patient don't need to start treatment at that point. So we can, again, as I said, we can delay this treatment. One of the things that have an effect is also that a lot of cancer patients, they're supposed to have their surgery, but they cannot, because surgery need anesthetist, and the anesthetists are all in intensive care. So what we also been done quite a lot means in the subset of patients, we're able to give them other cancer treatments, such as they will have chemotherapy first before their surgery. So that's just to bridge the time, when there was the peak, when the surgeons are not available, when surgery is not available, and anesthetist not available. So they are having their cancer treatment anyway. There was a time when we thought of having to close down one of our satellite unit, but luckily we didn't have to do that. So in a way, that's quite we're quite fortunate from that point of view. As I say, staff have service a bit stretched, because staff is a bit more what we call is this kind of redistributed. We talk about redeployment. There are rota changes, so now junior doctors have to go on nights. When previously they were not working any nights. Some doctors, healthcare professionals have to shield, like myself, so we have to work from home. Some healthcare workers are not immune to COVID-19, so some of them get COVID-19, so be off sick, or if their family have it, they have to self-isolate, and obviously people have to take annual leave as well. And in terms of the downstream effect in from the cancer point of view, now, as I say, things like surgery might get affected, but also in diagnostics, in people who are to have the diagnosis of cancer. So I suppose patients are not really going to the GP to start with, and secondly, when they do, they have to have this test, things like scans or scopes. And again, there's a reduced capacity for scans and scope because we just need because in terms of for so the allocated time is longer. Say previously you're able to do maybe 10 scopes a day, and now you have to reduce it down because you have to make sure that the staff are safe, and the patient are safe. So they have to increase the interval between the scopes. They also have to make sure that the patients also are not COVID positive. So you know so diagnostics get delayed, and as a result of that, patients might present a bit late as well. So once after the first lockdown, we are seeing more patients who are unfortunately presented late in their cancer diagnosis. Uh,
Right.
yeah.
So it's it sounds like on a whole series of levels, it's caused a host of problems, and you spoke about how treatment downstream is having to be delayed because you need to reprioritize, and there's a lack of anesthetist, and also the relevant support staff that could do the operations and the procedures. And like you also said, there's now a delay, and maybe there's a psychological element as well, because people who might be feeling like they should go for a diagnosis and I'm thinking, I'm not gonna bother because the queues are too long, and even if I call the NHS, they're not gonna pick up.
To be fair, we will pick up and we will try as much as we can. And this is just a snapshot of what I can see. There's a whole, whole gamut of things that I don't see. And I think one of the things that I'm quite that I've seen in the past week or so is that NHS has saying that if you have a cough, more than 3 weeks, it might not be COVID, it could be a sign of cancer. So if you do have symptoms that you worry about, do contact your GP and seek medical help.
Right, right. So as we're all aware, where the world governments now are starting to roll out their vaccine, and the UK has certainly done that. We've got the most vulnerable people receiving their vaccination, um, but also there's amidst all these global rollout of vaccine, there's a lot of misinformation, there's a lot of doubt, and there's a lot of concern amongst people, especially people who might have very little knowledge of how vaccines work. um, can can you kind of share some insight as to um, how vaccines work generally, kind of a layman? I know it's a complex topic, but to a layman, how do vaccines work, and why is it so important that people get vaccinated when there's a pandemic like this?
So yeah, so I'll just go through that question. I mean, it is a very important question, and I think it's one of the things that people want to know, I suppose. Um, so I'm just going to start by saying that the aim of a vaccination program is to achieve herd immunity, and what I mean by that is having enough people in the population to be immune to the virus or to the disease, or in the case is an that we are in now, again, coronavirus. And we can achieve this in two ways. And one way of achieving it is the strategy that was rumoredly, allegedly, was what the government wanted to try about March last year, is by infecting as many people as possible. Unfortunately, this has the consequence of this. It was at that point a very novel virus. It's a new virus. We don't know what it causes, and then the kind of the natural cause of the disease at that point. And we've learned very quickly that people get very ill. They've been hospitalized, and people die of the disease. So to achieve herd vaccination, herd immunity in that way would be unethical. So another way of achieving that is by using vaccination, which is the strategy that what the world is doing now. And again, and the way to achieve this is rather than exposing the people to the virus itself, is to expose the people to part of the virus, or the or weakened part of the virus, to achieve immunity against the virus. Um, so the idea of having so you ask the question, why do you need herd immunity? Um, the idea is that when people are immune to it, there'll be less people getting ill, there's be less people being hospitalized, and ultimately, hopefully, less people will die from the disease. And one of the things that have been also debated quite recently is whether vaccines able to reduce transmission, and we are seeing data now coming especially from actually Israel as well as the UK. A study in Cambridge just came out a few days ago saying among healthcare workers that vaccination does reduce transmission as well. Again, this is a cycle that we try to achieve. If we are able to reduce transmission, then we'll be able to hopefully go back to normality, opening up the economy, and this is done by lifting the social restrictions that we're in at the moment. How much herd immunity that we need to achieve in the population, and I think is quite unknown question, but I think the consensus among the scientists is about 80 to 85% of the population. So that's quite a lot of people that needs to be vaccinated. The idea of vaccination is not only to save lives, but to also, especially now we are 1 year into the pandemic, is to save livelihood, because we know all the social restrictions are having a very bad impact in an economy. And we've heard a few weeks ago where the UK GDP has shrunk to about 9.9%. So I'm just going to move on to the COVID-19 vaccine himself. So at the moment, there are 3 authorized COVID vaccine 19, and they are, for the sake of simplicity, they are named according to the company that made them. So we've got the Pfizer vaccine and the Moderna vaccine. So both are what we call mRNA vaccine. So mRNA stands for messenger RNA, and we'll talk about it in a bit. The homegrown, or the one that is made in the UK, or well, developed in the UK, not made, is distributed or made by Pfizer in conjunction with University of Oxford. So this vaccine uses a viral vector. So this comes back to your questions on how vaccines work really. So as I said, the way for humans to be immune of viral illness is to either expose them to the viral illness, and they become immune. In the case of COVID-19, that is not really appropriate. So as I say, we have to come up with another solution. There are many types of vaccines, and to be fair, most of us have had vaccine throughout our lives. And vaccines can be developed on different platforms. Things that we're very familiar is using inactive virus that has been inactivated, such as the flu vaccines that we have every year. There are also viruses that have been modified and be used as a vaccine, things like the MMR vaccine, the measles, mumps, and the rubella vaccine. You probably heard about the tetanus vaccine, and that uses the toxin that is produced by the microorganism, and use it as a vaccine. So as you can see, there are many platforms that are various ways that we can vaccinate people, but the idea is the same: expose it to part of the pathogen or the causing microorganism, or bug, as in the layman's term, and then and the body will recognize it and hence say, oh, this is not part of the human body, we need to fight it. So we'll go back to the vaccines that are available for the vaccination program in this country. So the Pfizer, as I said, the Pfizer and the Moderna vaccine are messenger RNA vaccine. So if we go back to our science classes many years ago, so everybody knows all living creatures are made of DNA. So they're the building blocks. So they are like the code for all the so that makes us. So in order for that code to be made into us, so they have to be made. We are made mainly of proteins. So so the step is the DNA is made into this messenger RNA, and then the messenger RNA is incorporated into your cells, and the cells makes the protein. Okay, so in the Pfizer and Moderna vaccines, so we take a bit of the messenger RNA of the coronavirus, and then we put it in a it's not very stable, so we have to put it in a vehicle, and the vehicle is a bit of fat, a bit of lipid, nanoparticles. They are very small, and it is injected into your body, and when it's injected into your body, the mRNA itself get released into the cells, and it will make part of the viral virus protein, not all. So this is a very small part of the virus, and the body recognizes and say, wait, this is not human, so we need to destroy it. As a result, the immune system saying the immune system start to make what we call T cells that attacks the protein and destroys it. But it also makes what we call memory T cells, which means that the moment the body will remember that it made the it has encountered this protein before, saying that okay, this is not us. If it comes again, then we need to destroy it as soon as it enters the body. That's the whole idea of the vaccination.
Right.
The second one is the other vaccine is the Oxford AstraZeneca vaccine. So that's another platform, and it uses a viral vector. So what it does, it uses a weakened virus, and that is an adenovirus which cause common cold, and it's actually a chimpanzee cold virus, not even human. And again, they inserted part of the RNA or the genetic sequence of the coronavirus inside the body, and then the vaccine. So the adenoviral vector, we call it a vector, or the vehicle, is being put into the body. Again, the same process happen. The body recognizes it as, oh, this is not human. Let's attacks it, and then and there's also the component of your immune system that will memorize or remembers that it has been encountered before. This is not good. If it comes again, then we need to do the same thing, and that's how you get protection through vaccine.
Right. Thank you so much for giving us kind of like a whirlwind tour of of vaccination. That's really important for us to at least have a cursory understanding of, because we tend to hear all kinds of things, especially online. There's rumors from people who might not have an understanding of how vaccines work, saying that, oh, I've heard that the vaccine is going to rewrite my DNA and cause all sorts of problems later on. And like you said, doctor, it creates an immune response. It doesn't alter DNA.
So yeah, I suppose the one of the thing is that it is based on the RNA of the virus. The is never incorporate. It doesn't really is not really incorporated into our gene. So it's not this is a there's a there's a process called transduction, which doesn't happen with this vaccination. And it can be done, but it just doesn't happen with vaccination.
Right. Um, in terms of the vaccination, that's you mentioned the various types of vaccinations out there, the three that has been authorized. Um, ca- I guess can you explain why there's more than one type? Is that just because it's a there's the science allows there to be various types, and because a lot of concern we're seeing is that, oh, um, there's a lot of different types because they there are these are new experimental types, and they've never been used before, so there's a lot of concern coming from that.
Yeah, I think no, that's a good question, and I think those are um, genetics in a way. Some people have concerns, and probably they have, to be fair, valid concern, because the one of the platform, which is the mRNA platform, is actually novel. And when the Pfizer vaccine was authorized, it was the first mRNA vaccine that has ever been authorized anywhere in the world. So but so is a so I suppose people can have a valid concern, and we need to acknowledge that. Um, the things that I always say regarding the authorized, excuse me, um, vaccines is that they are A, safe, and B, they are effective. And how do we know this? And we know this because we've done clinical trials on these vaccines, and now luckily we also have real world experience. Um, as you rightly say, so why they are different platforms, and as you rightly say, so we are able to have this different kind of platform because the science allows it. We have been making vaccines for, well, I suppose if you take from Edward Jenner, for like 200 years or so. But vaccination really has really changed the way that we tackle infectious disease for the past 10 to, well, 50 to 100 years, and we've managed to eradicate some of the infectious diseases that we have. So yes, as I said, there are many platforms before, everything from inactivated virus, attenuated virus. Now we have mRNA. Now we can use viral vectors. So I think the simple answer to that is because the science allows it. The thing that we need to say, despite the novelty of some of the platforms that's been used, is that despite despite it's being quite new, they have been rigorously tested. So and I've mentioned about clinical trials before. So clinical trials, firstly, the thing that for any drug, uh, all drugs or even vaccines, they will go through what we call a phase one trial. And a phase one trial is just to actually see whether the drug is actually safe. If a vaccine is not safe, say if they give 3 people in phase one trial and all of them die, then that vaccine development will be scrapped. Okay, and then so that's the phase one trial. So all the vaccines that have been authorized have gone through this phase one trial. When they pass the phase one trial, when they have enough people, and we confidently say, okay, there's no, and the vaccine is safe, we go on to what we call phase two trial, which is again just looks at the activity. So this is when they vaccinate a small number of people, usually healthy volunteers, and they say, okay, we can see, we talk about the immune response that this vaccine elicit. So they vaccinate the patients, and then a few weeks after that, they take their blood, or maybe a few days, do a blood test, see whether they can detect the T cells, the immune response. So they use different parameters, and see whether whether there are the presence of any immune response. Again, if this is achieved, only then you can go on what we call a phase three trial. Again, these are very big clinical trials. So the Pfizer and the Moderna and the AstraZeneca, I think they've gone about like, ten and thousands of patients. So there will be people, they've been put into 2 groups because phase 3 trials, what they want to achieve is to actually see whether this actually works in the population. So in the phase 3 trial, they put people in 2 groups: patients who get the vaccine itself and the people in placebo. So the numbers are big. They are in the 10 thousands of patients. And then this is quite incredible that we managed to do this and recruit patients all around the world, and get the recruitment, to get people recruited and get the recruitment done. And then we were able to get data, and we were starting to see data of efficacy back in October, November last year. And as a result of that, health authorities all around the world has authorized the use of these vaccines, of this vaccine. And I think as of even yesterday or today, there's been 234 million doses of vaccines have been given all around the world, and including, as you probably know from the news, about 20 million of people, almost 20 million people doses in the UK itself. So we know from the clinical trials that the vaccines are effective, and I'm sure you know. I mean, the three vaccines that we've talked about, have kind of efficacy of about nine mainly around 90, more than 90% for all three of them. And we also know about the side effects, and which I suppose we can talk about.
Yeah, exactly. I think you mentioned about the efficacy with which the trials were conducted, and how quickly they were carried out, and also how quickly they were authorized. Obviously, because of the pressing need of dealing with a global pandemic. I mean, the skeptics will say, "Oh, by doing everything so quickly, are we, how sure are we about the safety of these vaccines?" And you talk about the sample size of the trials, being uh, big enough for it to be authorized. Can you give us some insight as to kind of maybe like the observable side effects in the trials, and at what because people have concerns about future side effects. They're talking about, oh, we don't know about future side effects that might happen later on. Can you give an insight as to how safe these vaccines are, and how how these kind of more insight as to how these trials are taken are carried out, and how kind of side effects and concerns of side effects
Okay.
are observed.
Okay, so I suppose as I say, the way that we know about the safety and the efficacy of these trials are clinical trials, and also real life experience. And I think one of the things that is good in science is, if we see, and if you've been watching the news and you've asked scientists, and I think one of the things that is profoundly very very common among scientists is, if they say they don't know, then they say they don't know. So long-term effect of the vaccines, we don't know. And I think that is something that, we put our hands up. What is going to happen if you have the vaccine in a year's time? We don't know, because the first person in the world was vaccinated on the 8th of December. What's going to happen to her in a year's time? We don't know. What's going to happen to her in 2 years' time because of the vaccines? We don't know. So that is the importance of having surveillance after this vaccination has have been done. So they have been reported. So I'm just gonna go through just a little bit about the what we see in terms of side effects in the clinical trial. In the trials, as well as real world evidence as well. So to start with, in the clinical trials, I'm just going to use the Pfizer clinical trial, the Pfizer phase 3 clinical trial data, just an example. So in that trial, they say pain 75% of patients. Makes sense. You put a needle in you will have pain. Okay. About 10 patients have a I'm just trying to read my handwriting here. But yeah, just a bit of redness and on the injection site. Some of them, 15% of them would have swelling. So that's kind of like the local adverse event, what we call it, a side effects. And there's also what we call more systemic, that affects the whole body. So one of the things that vaccine skeptics say that we are normalizing side effects, but then again, if we actually understand the process behind it, then we know. Okay, giving vaccine is, as I said, it's just giving a part of the pathogen or the microorganism or the virus to you. So and as a result of that, you would generate an immune response. So if you have a flu, if you get a flu or the common cold, you get a fever, you'll get aches and pains in the body. So it is the same process that is happening in you. So that's why you have the side effects. And in the clinical trials, about 70 to 80% of the people are vaccinated do report some side effect. 60. So I'll give you example. 60% of patients would have headaches. If you haven't had flu or before, you notice this, you would have this. About again, just trying to read my handwriting here. Fatigue, 72% of patients have fatigue or tiredness. I must admit, when I got it, my arms was a bit sore for a day or 2 hours, be tired the day after, might get a little bit of muscle ache the day after. Went out, oh no, it went off about in 2 days. I will just feel a bit lazy as well the day after. Um, did I get it? I think I have a little bit of headache, but I was still functioning normally. So things like muscle pain, or muscle aches rather than pain, 60%. Things like joint aches, about 50%, and some of the or half of patients get what we call chills. Again, those side effects, if you notice, they are quite similar when you actually have the infection, but and they're quite common. So, and there's an underlying reason for that why you have the side effects. And the important thing big about the side effects, they are very, they don't last very long, a day or two, maximum a week. So that's in majority of patients who are vaccinated. So this is what we find in the clinical trials. So we're also getting data in a real world experience. So I'm just going to quote one study that's been published quite recently. You've probably seen it on the Facebook, on my Facebook page. So this is from data from United States. So they've been vaccinating again from December to January. So in one month, so they vaccinated about 13.8 million patients. So they collect all the data of the patients who, or not patients, they are called people, sorry, doctor. So sorry, just me being doctor, keep calling people patients.
Right.
3.8 million people in the United States were vaccinated during that month. So out of the 13.8 million patients, so only 6,994 adverse events were reported. So out of 13.8, 6,994. 600 out of that, 6,994, 6,354 was considered as serious, and 640 so 6,354 was considered non-serious, and 640 was considered serious. So a very so out of the 13.8 million, only 640 adverse event was considered serious. So that's like 0.00001% or something. Um, and in that whole period of time, 113 patients, again, people, sorry, not patients, died. And when they did the autopsy, when they did, and when they looked into the reason why they died, none of them were related to the vaccine. And in terms of the real world experience, again, the side effects that people described, the common ones are fatigue, tiredness, feel a bit meh in 16.5%, but 22.4% have had headaches, and 16.5% have dizziness. One of the concern that people have is regarding whether they will have reaction to the vaccine, and in this particular report that was released by the CDC a few weeks back, is the incidence of anaphylaxis is 4.5 cases per million. So in a million vaccines that been given, 4.5 had kind of have a bad reaction to the vaccine. And to be fair, we in the UK learned this quite early on, and because in the first few days, two healthcare workers were given the vaccine, and they had the bad reaction, and both of them actually had a history of anaphylaxis before. So as a result of that, and they're the ones who carry EpiPens, the thing that if you're allergic to nuts, and if they accidentally eat nuts, you need to give the EpiPen that they carry to treat them. So if you have a history of anaphylaxis, unfortunately you shouldn't be offered these vaccines. So the chances of you getting an a bad adverse reaction to the vaccine, if you don't have a prior history of allergy, or not really allergy, but anaphylaxis, is close to zero, really.
Right.
One question that people may have, that if they're allergic to antibiotics, I mean, that is not a contraindication to have the vaccine. so one of the things that they do before they vaccinate you is that they actually ask you whether you're allergic to anything. And not only that, in my, where I got my vaccination, they give you the list of the ingredients of the vaccine. So that would include the actual, I got the Pfizer vaccine, so the actual RNA and the lipid, the fat nanoparticle, but they also think like cholesterol, thing, potassium chloride, sodium chloride, sucrose, which is basically sugar, and some other chemicals which I've never heard of. So you will know what's been put into you. Um, I think I'm most reassured that there's no mention about microchips in there. So
That's yeah.
yeah, I don't think there's any microchip in the vaccine, or at least I'm not. Well, I'm not allergic to microchips anyway. Now that I've got both
You're not currently
vaccines.
being tracked by Bill Gates and his cohorts, I hope.
Well, I think if even if they are watching me, I think they're very disappointed in what I've been doing, being locked up in my room, well, in my flat anyway.
Right, and I think that it's worth pointing out because I have seen, unfortunately, I have seen these theories being bandied about mass tracking through vaccination, and it's interesting because tracking is done much easier than via vaccines nowadays. If you log into your email or if you go on Facebook, Google and Facebook is already able to track you. So it's I guess it's unfortunately it's because people like to be carried by kind of the stories that cause a lot of that stir a lot of scandal. And I think you segued into my next question, which was, why do you think, unlike, maybe this has happened in the past, but at least by my experience, like the level of conspiracy theory and the level of phobia is unlike anything I've seen before. And it might be because this is maybe one of the first global pandemic where literally it's open access to information and open access to opinions, and social media is accessible by everyone. So is that part of the reason? And what role do not only health professionals do, but the public, what role can they do to kind of navigate this kind of madness?
Yeah, so I think that, yeah, as you rightly say, so this is the first global pandemic that we have in the, well, I suppose we call it the modern age. The last pandemic was back in 1918. So I don't know how conspiracy theories relay the information at that point. Maybe they have just to give up flyers or send snail mail,
Right,
or one of those chain letters that, if you don't post
it'll
it,
take forever.
yeah, they'll just, yeah. I suppose is the matter of speed, isn't it? Um, so I mean, vaccine hesitancy is a major problem, and well, and I think in a way that, I suppose the way that I see it, that there are people who are hesitant of the vaccine because of legitimate concerns of the vaccine
Absolutely, yeah.
development process. But there are also people who are, don't, if you don't mind me saying this, just cannot be helped. To be honest, they will just pander in any disinformation that they can get hold to, and then I suppose in a way they are, um, and they are pandering to some kind of truth, but they twisted it twisted a little bit. I'll give you example in a bit. And is the way I see it is quite interesting that this is universal, but this has a local narrative to every to who you are.
Right.
Uh, so it's not confined to any single group, and the narrative is always the same: is us against them narrative. Okay, there's always a conspiracy against somebody else. Muslims against other religion. If you go to Israel, the Orthodox Jews, or it's the secular Jews who try to get us. If you go to America, the far right say, "Oh, is the agenda of the liberal left?" Bill Clinton, Bill Gates, trying to contact them. If you go to the Christian group, it's the secular people who try to control them. So it's, and if you take it collectively, just wondering. So this group saying is the other group. but the other group is saying the other group, and the other group is saying this other group. So who is actually trying to control? Who is controlling? So that's one of the questions that one can ask. And I suppose some of the problem is there might be a bit slight of loss of faith in the healthcare system. The against conspiracy theory again. Big pharma is making money, especially in the United States. Doctors are reimbursed according to what they and what they prescribe, so they are in the pockets of the pharmaceutical company. It doesn't also help. There have been you know there have been bad press against vaccines. We take the case with Andrew Wakefield, who linked MMR vaccine to autism, which was published in the New England Journal, which is the most reviewed medical journal in the world. But since we have debunked that is not true, the methodology of the study was fake, it was false, and also that we know that Mr. Wakefield, you know, had some other agenda. Dr. Wakefield has some other agendas as well.
Right.
Um, there's element, the vaccine has an element of, as we discussed, a bit of cultural, a bit of political, and a bit of social elements to it. There's, as I say, narrative of maintaining of the us versus them narrative. There's an element of maintaining one's identity, a sense of belonging to a group. And to be fair, some of the people just wants to be heard. So these are the people who just keep and just hold on anything. And to be fair, I mean, they probably started on something actually this which is true. So we just need to understand why. The infertility business, they say that
Right.
vaccine, it stems up back in the early 2000s in, say, Nigeria, which is a Muslim country. I mean, and it was actually the Nigerian government, who said that polio vaccination can cause infertility, and that's because, and the background and the context of that point is because of 9/11, and at that point there was a bit of a tension between the United States and the Muslim community because of 9/11. So that's how it stands for. And in terms of the microchip, we're going back to this microchip business again. There is a technology, and the technology is developed to actually with a good intent, and that technology is actually, you can actually give nanoparticles with vaccination, and the idea of this is to create what we call a digital vaccine record, and and this has actually been published, and this has been tried on animals. I don't know whether they've actually done it on humans, to be honest. But the idea is that when we vaccinate people, there's also this nanoparticle that is under the skin, and then we can track who has been vaccinated or not. So there is an element of truth in it, and then it has been extrapolated. Some of it might be people want to discredit others, to mask their own incompetencies. Things like Iranian scholars saying that vaccine can turn you into gay. Obviously, there's no evidence for that, and whether this is because the fact that Iranian governments didn't manage to secure any vaccine for the populations, we don't know. Then again, I'm speculating here. So I suppose we go to the questions of what we can do, especially as with the not the general public. There are three. So I suppose I would like to give you the 3 E's that I just made up earlier on, and those are educate, engage, and encourage. So I think part of I mean, don't get me wrong, there are patients, there are people who we cannot change their mind, but it's the undecided, and those are hesitants that we try to convince, and we do this, as I say, we educate. I think having these sessions, we present the facts, and just to give an overview of what's been going on. Unfortunately, to be fair, facts don't change people. As you can, we are adults. I mean, we watch world events, and we know that we see people that we don't agree with, and despite giving facts, they don't change their minds. Unfortunately, facts is the least is the least effective way to change people's mind. So we have to engage with them, and we have to encourage them as well. And engagement, I think, is good that we know that that people from the more ethnic minority have a high incident have a high incidence of vaccine hesitancy. Again, that could be more cultural, religious, and social reasons for that. And I'm very, it's good that the UK government is engaging with these people, having celebrities from these ethnic minorities to reassure people that to take up the vaccines, and saying that they're safe and they're effective. One of the things that maybe we can that maybe so far can do is, or any religious organizations can do, is to get people who are respected in the community, religious leaders who are respected in the community, to give the message out. And there's also this question of whether we should try to give positive reinforcement. I mean, we are 1 year into coming to 1 year into the lockdown now, and I think instead of try to um, try to sell the actual benefit of a vaccine, maybe we can say, okay, this is, and I think that, again, the UK government is doing this in a way and saying that this is the way to lift the lockdown. We want to go back to a normal life. So ask these people, what do they miss the most? Do they miss the most of going to work? Do they miss um, of just running their own business? Do they miss having money? However, just able to spend, go out to the park, or just do normal things. And I think we should reinforce that that the vaccine is one of the way, not the only way, but one of the way for normalization to happen. Um, we shouldn't scaremonger people. We've studies have been done, where in the context of measles vaccine, where one is to show pictures of people who didn't have the measles vaccination, and they see people dying of measles. That didn't really encourage people to take up the vaccine, and unfortunately, so engagement is important, and I suppose in our in individual level is encouraged. Your loved ones, your family, your friends, to take them, especially, our parents in their 60s, in their 70s. So they are, if they're in the UK, they're definitely eligible for them. And say again, positive reinforcement. This would help them see you, if they want to see you. They see their grandchildren, see their family. So positive reinforcement, encouragement is important. Yeah.
Right. And it's
And
interesting you spoke about positive reinforcement, because um, there's this field of economics called the nudge theory, right? So and I've heard some governments, I don't know whether they've applied this, but there's all kinds of perks, that's being considered. Like, if you take your vaccination, you'll be given a special permission to travel and to go on holiday. So I guess that there's, like you said, there's ways other than just the cold hard facts to actually get people to buy it into vaccination.
yeah, I suppose, yeah. I mean, as clinicians, I suppose at the end of the day, what you're there to heal people, and then as part of it is to engage and to talk and to allay fears and try to individualize. Uh, and 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 I think not all doctors can do that. If you believe in the vaccination, and if you and this, I mean, your role is to encourage others to engage with others. I mean, this is, we all sick of the lockdown, the social restrictions. There is a way of doing so. And I suppose in terms of the, as I say, involvement of the religious leaders is actually, especially in Muslims. I mean, as I say, they put down the ingredients of the vaccine in front of you, and you shouldn't be, um, what's the word, was or suspicious of what they put in,
Right.
whether it's halal or haram, because there's all the components are actually halal. Um,
And it's
so
interesting if I could just add on. You talk about engagement, and um, I think the public engagement is always going to be chaotic and riddled with misinformation. But I guess um, you mentioned about religious institutions. I guess the work that uh, organizations can do, community organizations, religious organizations, I guess there can be a lot more engagement amongst between scholars, Islamic scholars and preachers with healthcare professionals, because these are two completely different expertise. And kind of in Islam it's always like, when you're in doubt, ask the expert, right? So I think there needs to be that kind of discussion taking place between the religious institutions and the head of religious institutions and people who are well versed in vaccines, and with the hope that with with more kind of expert information and more insight, then that kind of has a trickle down effect onto the masses and onto the community.
So yeah, I totally agree with you. I mean, that's the approach that we should, yes, that should be, it should be tried, and should be taken. Um, I'm not a religious expert, but I suppose the way that I see it, is that God give us a disease, God give us the mind, and God give us medicine. So why don't use that medicine? Um, and 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 I suppose in a cynical way, there is a verse in Surah Ar-Rahman saying that, which one of God's gift that you deny, or something like that. Fabi ala ribkumat kaziban, or something like that. So yeah, I mean, for those who are hesitant, still hesitant for the vaccine, I mean, the way for them is I suppose that way is a bit, it's not blackmailing, or I think, but it's about engagement, allay their fears why, and try to understand why they don't want it. And it's usually people who are close to them who have the most effect, and hence my call for education, encouragement, and engagement.
Great. And for people who are watching now who are on the fence, um, what- is there anything you might want to share to them to kind of uh, give them a little bit of an insight or a bit of a motivation to, even if they don't get the vaccine, but just to kind of do their own engagement? What are the resources available where they can maybe do further research?
Well, I suppose the thing is just to speak to people who've had the vaccination. I mean, you don't have to speak to doctors or healthcare professionals and say how they are, how they feel. I mean, unfortunately, we live in our own bubble, in our own echo chamber. So if they are, I mean, is it might be good to talk to people who outside that the echo chamber, or outside the bubble. If you know somebody who had the vaccine, ask them how they are, what did they feel about the vaccine, and what do they feel about the vaccine. And have a discussion with your own family, your own friends, really. To be fair, there are, I mean, in terms of resources, there are a lot of resources. I mean, I would say that the government websites are quite good. The NHS websites are quite good. Um, Obviously, they will encourage you to take it up. At the end of the day, to be fair, it's your decision. But do it for the greater good. I mean, one of the things that I would say to people, our age, or people like us, is to speak to the loved one. If you don't want to do it for yourself, do it for me, do it for your family. Um, um, and there is also, as I say, ongoing data being collected as we speak. We all learning this together. I mean, I mean, I totally understand the concern that we are maybe authorize these vaccines a bit too quickly. And I had a lot of discussions with whether we should have given the two doses 3 weeks apart, or whether they can be given more widely apart as the government is doing. And then and it turns out that, I was a skeptic at one point that it cannot be given, but then data came in, and I started excuse me, started to see that, that this is an unreasonable thing to do. So ongoing, so yeah, I mean, we are learning this as we go along. And as I say, if there are red flags, whilst we're monitoring this, if there are things that, okay, this vaccine is causing this and this, you know it will come to light, and then vaccine will stop. And maybe at that point, there's the cases is suppresses enough that we don't even have to give the vaccine. Or if there is problem with the vaccine, we'll start again. We're talking about now adapting the vaccine to the new variants, but we can also adapt vaccines to reduce side effects as well. We just need to understand them. Um, so is a learning curve. As I say with science, we put our hands up if we don't know, and we also put our hands up if we did something wrong. And I think that is reassuring. It's not black and white.
Yeah, thank you for that. I think that's really important for people to take in. That kind of everyone is in this together, and we're all trying to do. We're all trying to beat the pandemic, and I think any kind of you versus us narrative only serves to kind of put a spanner in the works of fighting this together. I've got some questions on the comment section.
Mm. I don't. Oh, sorry, I didn't switch that on. Sorry.
Oh,
Oh
no, it's
gosh.
okay. I'll read them out to you, Doctor. There's one from Efe Roslan, and you actually touched on this just now. You said, Efe Roslan asked, "Thank you, Doctor. Will the decision to extend the gap between the first jab and the second jab affect the efficacy of the vaccine?"
So I suppose the okay. So thanks, Faisal. I can get this to you personally if you want, but there has actually been studies done with the done, and actually the response of the first dose actually goes beyond the 3 weeks. So the effectiveness has not actually been affected. I can get back to you personally regarding the study. So the quick answer is no. Question from, sorry, I'm just reading the questions now. Question
Sure.
from Sarah: why did you get 2 doses? One is so the first dose is to actually prime the immune system. So we call this a prime and boost the concept. So we know this from previous experience, and we've used this in things like hepatitis B. So you need to have 3 vaccines. So the first one is to recognize the pathogen, the microorganism, and then we got the T cells that attacks it, as well as the memory T cells that remembers it. The second one is what we call the boost, and that's kind of like fine tune the just to make sure that the that this is that is that that the immune system has actually takes place, the immune response has actually takes place. And it's also kind of like fine tuning what kind of immune response that should happen as well. So that's the rationale behind the second. This is called, yeah, the concept is called prime boosting vaccination, if you want to read a little bit more about it. um,
Great.
Thank you for all the love.
Um,
um,
One more question, and this is from me actually. I've listed it down, but I've missed it, and I hope you can shed some light on this. You mentioned about fertility, propaganda. Are there any data showing fertility side effects, either for people who are already for women who are already pregnant or thinking about becoming pregnant?
So I think the advice at the moment that pregnant women shouldn't get the vaccine for now, and I believe people who are breastfeeding as well. But then again, if you look at any drugs, so you
That's a
don't
common thing.
advise people to do that anyway. So I suppose in terms of fertility, me being a bit cynical. So at the moment, we are vaccinating people who are maybe less concerned about fertility. And again, I say we don't really have data regarding people whether this affect fertility. Over time, this might this might we might learn about it. The trials were done kind of like summer last year, towards the autumn. So we are still very early phases. Yes, we will know about it really.
Thank you so much. Thank you, Dr. Kam, for joining us and for sharing,
Thank you for
you know,
having me.
your insight and your knowledge. And I hope I certainly have been provided a lot of reassuring insight into the vaccine and how it all works. And you've certainly allayed some of the concerns that the viewers might have.
Thank
So
you.
thank you also to the viewers for joining in. I hope you found it useful. Again, if you have any questions, you can continue to engage with us, and I hope that we can continue this engagement just even beyond this show and keep the momentum going. Um, Again, Dr. Kam, thank you for joining us. To the viewers, we'll see you in the next.
So yeah, I just we are over time. Sorry for talking too much.
No, not at all. I think it really passed by so quickly because there's a lot of things to cover. So I hope we can get another session even to delve
Yeah,
into other
yeah.
topics.
Thank you for people who are watching as well. Some of these people I know, so thank you. And hope I suppose at the end of the day, hopefully we will all get to meet each other again.
Inshallah, Ameen ya Rabbal Alameen. Ameen, Ameen. And with that, I bid you all farewell. Have a lovely weekend, and we'll see you in the next session of Brothers Hour Special. Until then, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.